Hello, thank you for viewing this provider training for the Reverse the Cycle program that is being implemented in the emergency department at Mary Breckinridge ARH. Today, I will review with you the Reverse the Cycle model and how it's being implemented at Mary Breckinridge, and help you understand the role of the provider in one of the components of the model, which is the medication for opioid use disorders initiation in the emergency department. To give a little background about why we are here, the Reverse the Cycle model is a comprehensive substance use response program that is designed to work in an emergency department. This program has been implemented in over 50 hospitals across the nation, including Highlands ARH, Harlan ARH, Hazard ARH, and Whitesburg ARH. This model includes three components that are focused on capturing the most at-risk substance-using patients that present to your emergency department. It includes nursing administering a universal screening to identify these patients. After these at-risk patients are identified, there will be staff available to provide an intervention. These staff are called peer recovery coaches. They will address the needs of a variety of substance-using patients, including those who are overdose survivors. They will also work closely with you to identify patients that are eligible to receive an initial dose of Suboxone in the emergency department, along with the referral to treatment. In this training, I will walk you through each of these components of the program so that you clearly understand your role within the Reverse the Cycle protocol. As we look at substance use, we recognize that it is a national public health crisis. To understand the importance of having a model like Reverse the Cycle in your emergency department, I'll provide some context and share data on substance use nationally and locally in Kentucky. In 2020, there were over 100,000 drug overdose deaths reported. 2/3 of those deaths involved fentanyl or another synthetic opioid. Kentucky overdose deaths rose by nearly 50% in 2020. That's close to 2,000 fatalities. According to the National Institute for Healthcare Management, in the previous year, 2020, there were over 60,000 opioid-related deaths. There has been more than 1,000 increase in opioid overdose deaths. As the rate of deaths grew, the minutes between deaths fell correspondingly. By 2020, one person was dying of an opioid overdose every 7.75 minutes. Nearly 75% of drug overdose deaths in 2020 involved an opioid. In the last 6 years, we have seen spikes in the number of drug overdose deaths among Kentucky residents by certain drug types. With special attention given to fentanyl and methamphetamine, we see fentanyl deaths rose by 958 and methamphetamine rose by 423. There hasn't been too significant of a variation in rates for prescription opioids, benzodiazepines, or cocaine. Those have remained pretty steady. And lastly, heroin, we have seen a decline in these rates. Now, you might be wondering what can be done to confront this crisis. I'll now move on to providing an overview of how the Reverse the Cycle program addresses the national substance use epidemic we are facing. The Reverse the Cycle model is a comprehensive substance use program. There are three components of this program. One is universal screening and peer intervention. Then there's the Overdose Survivors Outreach Program, known as OSOP. And then there is the initiation of medications for opioid use disorder in the emergency department. I'll now walk you through how Reverse the Cycle will be integrated into your existing workflow in the emergency department. The Reverse the Cycle protocol has been approved at a system level by leadership across ARH. This protocol includes having all emergency department patients ages 18 and older being screened by their nurse during triage. The screening tools are located in Meditech and include a series of questions used to determine a patient's risky substance use as it relates to alcohol, prescription drug misuse, and illicit drug use. If a patient scores a 7 or greater on the Audit C, which is the tool to determine risky alcohol use, and/or answers yes to either of the two drug questions asking about a patient's prescription or illicit drug use, they will be considered a positive screen. There are also what we call exclusion criteria that result in a positive screen as well, which I will share with you on the next slide. Here you see a screenshot of the screening tool used by nursing, which begins with the exclusion criteria. Some criteria, if met, will not lead the patient to participate in the screening. There are other criteria, if met, that will lead the patient to be considered a positive screen. For example, if a patient is under the age of 18, nonverbal, or critically ill, they will not participate in the screening. Then there's the criteria of being identified as an opioid overdose, non-opioid overdose, intoxication, or provider requests, which will lead a patient to screen positive, but does not require nursing to ask the questions pertaining to a patient's alcohol or drug use. The idea behind this is that if a patient meets either of those criteria, the likelihood of them effectively responding to those questions is impacted. Therefore, their identification alone by nursing that they meet either of those criteria will lead them to screen positive. If the patient does not meet any of the exclusion criteria, then the nurse will proceed with asking the 3 audit C questions and 2 drug use questions you see below the exclusion criteria. If a patient screens positive, they will have a peer recovery coach come into the room to speak with them about their substance use. A peer recovery coach is someone who is in long-term recovery and they have lived experience with alcohol and drug use. There is screening criteria identified as provider requests. This should be used by nursing if a patient will not answer the screening questions and the nurse or provider suspects the patient may use or drink at risky levels. This criteria may also be used if a patient screens negative on the adult expert screening and you as the provider suspect the patient may use drugs or drink at risky levels. You should tell your nurse this criteria should be entered if you would like a peer to consult with the patient. The foundation of this program and the individuals who will be working with substance using patients in the emergency department are called peer recovery coaches. Peer recovery coaches are individuals in long-term recovery from substance use disorders that have been trained in motivational interviewing and other skills to use their lived experience to help patients that are in active addiction. These individuals will have a conversation with patients who screen positive for risky alcohol or drug use. They will also make referrals to treatment as appropriate. When Reverse the Cycle goes live at Mary Breckinridge, there will be peer support services that are shared across Mary Breckinridge, Hazard, and Whitesburg. This means there will be a total of 5 peer recovery coaches that will provide support across each of these 3 hospitals. If a peer is not on shift at Mary Breckinridge and there is a patient who screens positive on the adult expert screening, a telehealth intervention will occur with a peer recovery coach who is seated at one of the other hospitals. This could be Hazard or Whitesburg. There have been 4 peers designated to provide support to patients in the emergency department, and 1 peer designated to provide support specifically to patients that are identified as an overdose. There have been clinical staff designated at each of these hospitals who will be responsible for working with your hospital staff to assist with setting up the technology for the peer to complete a telehealth intervention with the patient. There will be coverage by the peer recovery coaches 7 days a week between the hours of 8 a.m. and 10:30 p.m. These hours are subject to change as we continue to monitor patient utilization in the emergency department to better understand what hours there should be shared peer coverage across the 3 hospitals to make sure that we're capturing most at-risk patients. The second component of the program is the Overdose Survivors Outreach Program. This is also known as the OSOP program. This component of the program will help address the overdoses in Leslie, Perry, and Letcher County. The OSOP coach will provide community outreach to these survivors. The support that will be offered to patients is really focused on working with the patient to prevent a subsequent overdose. The OSOP coach will have weekly and sometimes even daily contact with patients to support their recovery. Once the peer who is working in the emergency department has spoken with the patient, if the patient has reported any opioid use, we want to consider them for a dose of Suboxone in the emergency department if they are motivated to go to treatment. Mosaic has implemented this in hospitals across the nation since 2014, and it has been about 6 years since we have been working with hospitals to provide a dose of Suboxone to patients who are opioid using in the emergency department. Next up, I'm going to share with you an overview of the part of the program that involves patients receiving an initial dose of Suboxone in the emergency department at Mary Breckinridge. There's a great deal of research and science that supports medication-assisted treatment for opioid use disorders does save lives. I'll now share with you some of that research. It has been found that medication like Suboxone is estimated to reduce mortality by up to 50%. It has been linked to reduced risk of overdose-related deaths, and the risk of opioid overdose death declines immediately when patients with opioid use disorders are initiated with Suboxone treatment. Furthermore, Suboxone is associated with improved social functioning, decreased IV drug use, reduced HIV transmission, HIV diagnosis, and better quality of life. In terms of how Suboxone works, as you know, there is a ceiling effect, so the patient cannot get high. There is also the naloxone present that blocks the opiate effect if injected. You may be familiar with the D'Onofrio study out of Yale, where there were similarly out of an emergency department, they had 3 study groups. One was initiated with the medication and a 3-day prescription with a referral to a primary care provider with continued maintenance therapy. One group received a brief intervention and then got a referral to treatment with no medication, and a third group received a simple referral to treatment. And what you can see in terms of engagement at treatment in 30 days, there was retention and any self-reported illicit opioid use, as well as their toxicology report for opioid use. The group who received the medication in the emergency department with that coordinated link and bridge to care did better across all 3 components, and they were retained in treatment at a 78% rate, much higher than the other 2 groups. Their self-reported illicit opioid use was fewer days, and their urine toxicology negative was at a higher rate than the other 2 groups as well. When we think about practitioners using narcotics to treat opiate addiction, there is a separate registration or waiver needed. The Drug Enforcement Administration has an exception to the registration requirement, which is known as the 3-day rule, which allows practitioners who are not waivered providers to administer but not prescribe narcotic drugs to patients for the purpose of relieving their acute withdrawal symptoms while a patient's referral to treatment is being arranged. Under this exception, emergency department physicians are permitted to administer the medication to patients for no more than 72 hours. If there are any patients that present to the emergency department on, say, a Friday evening and cannot get into treatment the following day, you are permitted to provide them bridge dosing until they are able to attend their appointment on the next business day. The patient must return to the emergency department each day to receive their dose. When we think about initiating medication in the emergency department, we know that patients who begin or are already experiencing withdrawal when they are in the emergency department could receive a combination tablet of buprenorphine and naloxone to feel better, allowing them to participate more actively in their health care. When patients feel better, which happens almost immediately after receiving the dose, they understand their discharge instructions better, they're less likely to leave AMA out of fear of getting sicker, and when they feel better, they are less likely to use an illicit substance overnight before they go to treatment the following day. We also know that when patients receive a dose and avoid illicit drug use, they're more likely to engage in treatment within 24 hours. And when we look across our hospital data, we know that patients who received a dose of the medication in the emergency department show up at a rate of 65% to 70%. So there is a very high likelihood that they are going to enter treatment the following day. The way this component works is that the patient is already screened positive and has received a brief intervention from the peer recovery coach. Through that conversation that the patient has with the peer has determined that the patient is motivated for treatment and is willing to go to care the next day. Those are really the 2 components the peer is figuring out, that the patient wants to go to treatment and they're willing to go the following day. At that point, the peer recovery coach is going to talk to the provider to let them know the patient is motivated, opioid using, and should be considered for a dose of buprenorphine in the emergency department. The provider is then going to assess the patient for any exclusion criteria, which I will review with you as a part of the ARH protocol. And then you as a provider will order the clinical opiate withdrawal scale. The nurse is going to conduct the clinical opiate withdrawal scale, which does exist in Meditech. If the score on this scale is 8 or greater, then the provider will order an 8 milligram dose of the medication. The nurse will then administer and observe the patient is taking the medication. And meanwhile, the peer recovery coach is working to coordinate the patient's care for the same day or the following day. I'll go into this in more detail, but those are what we call fast track providers in the community who we've developed protocols with so the coaches can refer patients to them either same day or next day. for continued induction and maintenance. When a peer has recommended the patient be considered for a dose, there are some exclusionary and cautionary criteria the provider must consider. So, we do not want any patients to be on any long acting opioids for pain. If there's any evidence of liver disease, or if the patient is in any acute psychiatric stress and unable to consent to treatment, then we would not want to consider them. Or if the patient reports an allergy to buprenorphine or naloxone. We also want providers to proceed with caution, but not exclude the patient entirely if there's any prescribed or listed benzodiazepine use or if the patient's pregnant. Neither of these disqualifies the patient, but we do want to make sure that you feel confident dosing the patient and proceeding from there. Here I've included the MAT order set. When the peer notifies the provider that a patient should be considered for a dose, there is also a trigger that notifies you it is time to consider the patient for any exclusionary or cautionary criteria, and there is a MAT order set that you will be able to follow in Meditech. You will see it includes the exclusion and cautionary criteria at the top. It also includes nursing orders for the clinical opiate withdrawal scale, the medication, which is mentioned as an 8 milligram dose, and the consult for the peer recovery coach. As part of the medication for opioid use disorder initiation in the emergency department protocol, it is also important to make sure that the patient meets the DSM 5 criteria for a substance use disorder, which is outlined here. When giving patients an 8 milligram dose of the medication, we have not seen a high rate of precipitated withdrawal occur. But we do know withdrawal is more likely to occur when there is a level of physical dependence that is high, or there has been a short time since the patient's last opiate use, or if that initial dose of the medication is too high. So again, that's why we do the clinical opiate withdrawal scale to make sure they are far enough into withdrawal that we might prevent precipitated withdrawal. And we look at that exclusion criteria and cautionary criteria. If the patient happens to go into precipitated withdrawal after you've administered or the nurse has administered that first dose, we recommend that you give a 4 milligram dose to the patient in addition to that in order to try and prevent or end their precipitated withdrawal. Displayed here is a screenshot of the clinical opiate withdrawal scale. As I mentioned, the nursing team will be doing the clinical opiate withdrawal scale. This is a series of 11 questions that the patient can score on, and any score of 8 or greater makes the patient eligible to receive a dose of the medication. While the provider and the nurse are working on administering the patient's dose, the peer recovery coach is arranging for the patient to be referred to a fast track provider. Fast track providers are an existing network of community providers Mosaic has worked with that have committed to receiving patients from Mary Breckinridge's emergency department who have been dosed. These providers are ready and willing to accept patients from the emergency department the same day or next day for continued maintenance. Each fast track provider has a unique protocol the peers will follow to schedule patients and appointments. The peer recovery coach will not recommend a patient to the provider to be considered for a dose unless the patient has confirmed they will attend treatment and there is likely an available appointment the following day. A few confirmed fast track providers for Mary Breckinridge include the ARC, MCHC, Sparrow Health, and Behavioral Health Group. The Reverse the Cycle program will be going live at Mary Breckinridge on August 1st. The peers are in training with the Mosaic group the week before go live. Tiffany Latham, who is a senior behavioral health consultant with the Mosaic group, is the primary consultant with you who will be working on Mary Breckinridge ARH's implementation of this program. She will be providing in-person and remote technical assistance to support the peer team and you throughout this process. Her phone number and email address are listed here. She will be checking in with the peer team almost daily and working with the planning team to continue with the supportive implementation. Thank you so much for your time, and please reach out to Tiffany with any questions. Have a great day.